It's working. All right, team. Here we go. All right. So welcome. Thanks everyone for coming out. Really, really appreciate it. This is very exciting for us. We are doing our CFAAR treatment series, Eczema and Skin Conditions panel. And I am going to let our amazing speakers tell us a little bit about themselves so that you know how incredible their bios are. And we are going to talk about all things eczema. And we are recording this, and we also have a Zoom. So just know there's the world of Zoom watching and going to be asking questions in addition to all the lovely people in the room. So eczema is a really big part of what CFAAR does, right? It's the beginning of the atopic march. It is, the biggest risk factor for food allergies, which is a big part of what we do, and then leading on to asthma. So how do you manage eczema? How many people in the room have eczema? B, yeah. Thanks for being honest, but dry skin. Everyone, yes. So, what's the difference and how do you tell them? And is it really significant? We talk about this all the time. I'm looking at Wahida and Lucy because we battle this. Is dry skin the same? Is it impacting, the atopic march in the same way? But then even when you grow up, like Ria over there, and have eczema still, how do you take care of it properly? So every stage of life from beginning to, all of us, how do you manage it? And we have two incredible dermatologists here to talk to us about this today. So would you mind, Peter, starting out and giving us a little, and then you'll be able to come up here and start your slides, but tell us a little bit about your amazing career.
I don't know if it's amazing, but first of all, thank you so much for having me. It's a pleasure to be here and an honor. I'm Peter Leo. I'm a dermatologist just about a mile west. I walked over, in fact. My office is in River North, and I am also affiliated with Northwestern. I'm a clinical assistant professor of dermatology and pediatrics, and I have had an interesting journey, but about 15 years ago, I was told that I have to focus, that I couldn't be a general dermatologist, and that was Dr. Amy Paller. And I said, but I like general dermatology. And she said, no, you have to pick something. And I shrugged my shoulders and she said, you will do atopic dermatitis because that is a tough area. We need you. And I was like, okay. And it was actually prescient because it has really been an area that has exploded. And since then, I've started a little center devoted to atopic dermatitis called the Chicago Integrative Eczema Center. And I get to do lots of interesting positions with the National Eczema Association. I'm a scientific advisory committee member emeritus. I'm on I'm a member of the board of directors. And I really get to be kind of in the room where it happens for a lot of these big discussions with different companies. I do a lot of advising and speaking. And most recently, I've gotten to play a small but very exciting role with the development of Yobi and thinking about how that affects patients with dry skin and are there unmet needs. So it's been really an exciting time. This is now the decade of eczema.
All right, that's a tough one to follow. I'm Raj Chovatia. Pleasure to see you guys. I like to consider Peter a dear friend and colleague, in part because we meet like this all the time, and that's an understatement. Though typically not in Chicago, it's other places around the country or the world. I'll be seeing you in Vienna next month.
Yeah, no wait.
Right. Okay, perfect. So what can I say about me? Born and raised in the Chicagoland area with roots that go quite deep here. I spent a good chunk of time at Northwestern where I directed the eczema center here, as well as our clinical trials unit recently.
Terrible negative impact on society as a whole, and even the clinicians, right? Clinicians who take care of a lot of eczema kids, you feel that when you walk into the room, that autonosis, your own emotions drop down. You feel the weight, you feel the sadness, you feel the despair, and you have to kind of gear up and energize and give hope and say, we're going to turn this around. We're going to do this together. We're going to find a way. And that's what keeps me coming back, because usually, not always, I have a lot of failures, a long list of failures, but usually we get people better. And that is the most exciting thing when someone comes in and says, I really think this is working. I actually slept for the first time 3 nights in a row. The kid is actually acting different. They're acting like themselves. The skin is actually healing. You feel this incredible change, and that's really important.
Yeah, with the burden of disease, I'm convinced by that. But in case you weren't, and numbers are sort of your thing, maybe a couple points to just tell you truly how prevalent and common atopic dermatitis is, and it surprises a lot of people, right? So for some of our really good epidemiologic studies that I'm sure Peter and I have been a part of in some way, shape, or form, it's estimated about 10% of individuals in the entire country have atopic dermatitis, ranging anywhere from really, really mild to severe. Now, the actual sort of more severe end of that bucket is smaller, and maybe sort of that moderate to severe group is somewhere from like a third up to 40%, maybe. But these are staggering numbers when you think about it. And when you sort of then consider the fact of cost that Dr. Leo talked about, we can look at cost in a lot of different ways, right? So, from the actual direct healthcare costs, the last time this was done for atopic dermatitis, which has now been nearly a decade, we're talking about several $billions, right, in terms of cost. But what that fails to account for is the indirect cost, which is huge for this disease. You think about people taking time off, attention off, people being distracted, not being the normal selves, being able to deliver as a member of society. That's actually another few $1 billion as well. So when you add all that up together, the last figure we had was somewhere in the neighborhood of around $5 billion a year of cost attached to atopic dermatitis that we can measure. That's pretty big to me when you think about a disease that 1 out of 10 people has at some point in their life and has a cost in the billions. But then there's the other hidden burdens of disease that are really hard to measure except through various outcomes that we talk about. We heard about sleep, mental health, itch, pain, a lot of comorbidities as well. And it's not easy to measure these things too. But when you sort of put it all together, it's the reason why we talk about this disease as being multidimensional and having a lot of different ways to describe what patient burden is.
I love it. You know, what makes me think the indirect cost concept, there's something that's, I think, analogous in terms of, you know, we know what absentee means, right? You missed school, you missed work, you were absent. But there's that concept called presenteeism, which means you were there, but you weren't really there. You were exhausted, you were half asleep, you were definitely not your best.
Like every day in clinic, man. I'm telling you, that's my best.
That's because of video game shenanigans till 2 o'clock in the morning. But for these patients, right, they're really suffering. So it's just fascinating to think about how that's hard to measure. We can't measure it, but you feel it. You know it's there.
Yep. Great point. It's one thing if you ever read studies, and that's probably where I think Peter is going. There's these measures that we do to look at sort of activity impairment and activity sort of like, doing and work and stuff. And there's ways to numerically categorize this, but people are always surprised to realize that just counting how much someone is not around doesn't really deliver. Because if you think about someone that hasn't been sleeping, someone who's very distracted, obviously they're not going to be doing X every single day that they're able to do. And when you think about all those other things too, the actual personal safety, we know there's increased automobile accidents, personal injury, people going to the hospital. Oftentimes it has nothing to do with the disease itself. It's literally because they're distracted from their disease and exhausted and not paying attention to what's going on.
It's so important. And I think there's kind of a couple things that come to mind when we think about this. It's that we're trying to quantify not just how it looks, right? There are real limitations. So typically what we'll see in a clinical trial is what's called the IGA score, Investigator Global Assessment. You're clear, almost clear, mild, moderate, or severe. But that's like so limiting. It's like, just how do you look that day? What I see on your skin, how does that classify somebody who's maybe not sleeping for months at a time? And it also fails to encompass the dynamic nature of the disease, the ups and downs. It fails to really encapsulate the body surface area, right? Because you could have somebody with severe hand eczema, they're an IGA score of 4, they're severe. But then you have a kid who maybe is a milder score, moderate or mild, but their whole body's involved. So I think these are really limited. What I've been interested in the last couple of years is that thing called the ADCT, the Atopic Dermatitis Control Tool. And this is remarkable. It's 6 questions. It takes 45 seconds to ask in clinic, or you can even have patients do it before. And it scores them basically from 0 to 24. And what I love about that is that you then have a number that captures more than just how they look that day. It captures sleep. It captures some of the mental aspects of the disease. How much has it bothered you in the past week is one of the questions. And I love that because they've set a standard that you want to be below 7 on that to be considered in control. And when I learned this, I thought, oh my goodness, this is it. This is the right question. Severity is nebulous. It doesn't mean much to me. The other problem we have very practically with severity is you have a patient who's severe. They're a mess. You put them on a drug. They get better. They come back. And I'm like, great, now they're mild. Then the insurance company calls and says, they do not qualify for that drug. It's only for moderate to severe patients. And you're like, but they're only not severe because they're on the drug. What am I supposed to do? Right? It's ridiculous.
Yeah, this idea of sort of dimensionality to burden is an interesting one, because I love asking students or residents, when you say severe, this patient has severe disease, what do you mean? Right? Because severity can mean a lot of different things. Are you talking about one area on their skin? Are you talking about how much of their body is involved? Are you talking about what part of their body is involved? Hands and face are maybe different than elbows and knees might be. Are you talking about the symptoms associated with the disease? Forget about what it looks like. Are you talking about the comorbidities associated with the disease? Asthma, food allergy, hay fever. Are you talking about the long-term course over time? It's just been getting worse since they were younger, and it waxes and wanes multiple times in a year. Are you talking about their actual response to treatments and the fact that it has not responded or sometimes responded? Maybe it's adverse events related to treatment. Is it the actual quality of life impairment? I just named about 8 different domains that kind of go into your mind when trying to conclude severity. But as Peter so nicely put it, for the agency itself, when we want to get a drug approved and when we're sort of in clinic, we kind of boil it down to this clear, almost clear, mild, moderate, severe, and it really fails to capture everything that's going on with the disease.
It's so true. Okay, what causes it? This is the key question. All of our patients want to know, what is the root cause of the disease? And it is really frustrating because I don't think we know what the root cause is for most people. But I do feel pretty confident that this figure, which is what I'm going to have tattooed somewhere on my body at some point, I love it. I think it's brilliant.
Right here.
Yeah, probably right in the chest. Yeah, but I do have a T-shirt. Yes, I have a T-shirt with this on there, which I love. Sorry about copyright infringement, but it's just my own personal use only. But it's remarkable. I think it captures what I call the pathogenic pillars of this disease. I think this has 5 pathogenic pillars. On the top, you could see the skin barrier, right? We know there's barrier dysfunction. The skin is leaky. What does that mean? Well, it means water gets out too easily and you lose as little as 10% of the water in your stratum corneum, you feel itchy. So that's part of it. But more importantly, it means that allergens, irritants, and even pathogens can get in an abnormal way. That is big. And that's a huge problem for a lot of people. We know there are, of course, some genetic deficiencies where you have a leaky barrier from birth. It also turns out that we're talking about skin right now, of course, which is that's our passion. But if you follow your skin around your lips, now you're talking about the gut. Right? That's your gut epithelia. You start picking your nose, you're touching your respiratory epithelia. So these are all intimately connected, and probably the skin reflects these other epithelia. This is probably not just limited to the skin. In fact, we're already seeing most of the patients with atopic dermatitis have dysbiosis on their skin, which is the next one in our little circle if we look at the 9 o'clock position, but they also have gut dysbiosis as well. So this is actually, this is a whole body, right? This is a whole holistic kind of concept. Then as we follow that curve down, we see the immune system is involved. There's tremendous amount of inflammation, particularly the Th2 pathway allergic type of inflammation. Now we keep going. And of course, we get to a very interesting concept, the nerve endings. We know that it can directly drive some of the inflammatory cytokines, IL-4, IL-13, IL-31, the master itch cytokine. They can directly drive the sensation of itch. And then, of course, that makes people scratch. You see the little hand, that's the 5th pillar. It's the mind-body connection, the psyche, the scratching behavioral and habitual piece. A lot of teenagers, right? They're better as we're talking. They're feeling better. They're telling me they're sleeping better. I see them start scratching. I'm like, are you actually itchy right now? They're like, oh no, sorry, just force a habit. And it's like, wow, that's important, because here's the kicker on this slide. It's not that all these exist independently. They're all intimately connected. Many of them are bidirectionally connected. You could start anywhere. The primary insult could be anywhere, and then it brings all of these pathogenic aspects in. So it could be a problem with the microbiome first. It could be a problem with the barrier. It could be something that triggers your immune system. Once it starts, though, it doesn't matter what the primary mover was, right? I always say it's like a forest fire. Maybe it was a little kid from Cleveland who was playing with matches, and that's why this forest is on fire. That kid's gone. He's at home in bed. You could arrest him. It's not going to help the forest fire. You got to put out the fire now. Knowing that that was the problem doesn't solve it. It's still good to know. It'd be nice to know. You'd say, hey, don't let that kid back at this national park. He's a pyromaniac. But a lot of times you don't know. And the other problem is, of course, when you have a damaged barrier, then anything almost anything can become a trigger. People become very brittle. So it could be stress. It could be something that's irritating. Little babies, I think, they get passed around. People are holding them. Somebody's fabric of their coat can irritate their face. That's all it takes, that little tiny insult. And then they're off to the races.
I love how it took only 20 minutes for you to lay one down on Cleveland. That was pretty good. So
No offense to Cleveland.
a little bit of offense probably to Cleveland. So I'd say that this really highlights a existential debate that existed in atopic dermatitis for years and years and years. And Peter got a chance to live through a good chunk of this. I kind of got the tail end of this. Inside out or outside in, what camp do you fall in for atopic dermatitis? And believe it or not, this was a very we choose sides kind of thing here. Essentially, the idea being, is it the environment that is causing stuff to happen and that's driving what we see? Or is it stuff that is inside that is then leading to the environment to interact with you in such a way? And it's interesting that this occupied such fervent debate. And now we've kind of come to the point where we're all like, it was probably a stupid debate. It's all happening at the same time, right? And so much as you heard up there, maybe there's one thing that triggers it all. Maybe it's a little bit of everything together. It sort of maybe doesn't matter until we perhaps get to a point where we understand the order of therapies and perhaps there is some type of early intervention on one of these things that makes a difference. We're not there yet. So as far as we're concerned, it's essentially pushing on one of these that then push on the others. And most of our treatments nowadays push on the immune dysregulation part, which we've learned is probably the most efficient one at then correcting the other ones. When you sort of try to primarily correct the microbial part or primarily correct the barrier part with use of good moisturizers and whatnot, or you try to correct even the neuronal part, there's some degree of efficacy. And perhaps even for the mildest folks, you can push them into being clear, but it doesn't seem like that alone itself when they have full-blown atopic dermatitis is enough. So it is a fascinating question that is it a matter of time? If you catch someone early enough, can one of these nodes be the pressure point to driving someone back to normal? Or is it really the immune part that's the most important? And we're really thinking about secondary regulation of all of these central to the immune process.
And thank you for bringing that up, because that makes me think about another important concept, which is the portion of this problem of time. And it's that if you let the disease keep going, is it possible that it will continue to worsen? And then conversely, if you catch it early, could you potentially modify the course of the disease to make it less severe? And then not just the atopic dermatitis. What about the allergic comorbidities? Because in some ways, I think food allergy is even scarier and worse. And I'm glad I don't have to handle it. I sent it to this wonderful doctor in the second row who takes care of it and makes my worries go away. Thank God. Because I don't know what to tell these poor patients. But is it possible that we're getting sensitization through the skin for at least a chunk of these patients? I think we're pretty convinced that's the truth. And can we stop it by getting the barrier under control?
Can we take quick questions?
Please jump in.
Yeah, we'll keep this interactive.
So thank you so much. So one of the things you just mentioned, it just kind of struck me, but one of the things that we like to do at the center is try to recognize these young babies who have eczema as soon as possible, because while we have great guidelines for children to start eating certain foods early in order to prevent food allergies, some kids just get sensitized or they just don't start eating early enough. So just kind of knowing who's truly at risk and maybe starting a specialized kind of program for them is something that we often talk about. So what are the earliest signs? Because sometimes we're trying to figure it out 2, 3, 4 months of age. What are your earliest signs of eczema? I know that if it starts that early, it's a signal for severity, but what are we looking for at that young age?
Not an easy question.
Yeah, it's an important question. It's great. I wish I knew even more. I'll tell you what my teacher used to say, Steve Gellis at Boston Children's, who was a Jedi of diagnosis, really just could walk into a room and knew what was going on and could never tell you why. Just like, yeah, I don't know. It just kind of looks that way, and was always right. It was maddening. And he really felt that for many patients, the first sign was seborrheic dermatitis, that you would see babies with cradle cap. And it all starts coming back. And then it would begin to involve those cheeks. And he would talk about this moving down. So he used to think, and this has been 20 years now, I don't know if he still thinks this, but he used to say, I wonder if there is a pathogenic yeast that's playing a role in this whole story. And again, I think he was ahead of his time because he already was thinking about dysbiosis. That yeast may or may not be pathogenic. I don't know, but it certainly could be a marker of dysbiosis, because we know when the bacteria is imbalanced and what happens is the Shannon diversity index collapses, you get staph overgrowth. Well, it's not crazy at all to imagine that a pathogenic yeast or just some opportunistic yeast like a Malassezia sympodialis or globosa goes crazy. And that's what we're seeing in those early cases.
Interesting propositions. We can make this like ESPN. I'll take the other argument. So I'll say that what we're learning about seborrheic dermatitis, and sort of something that a lot of my group is working on too, is that it's probably a lot more similar than we realized to atopic dermatitis, right? That there is actual considerable barrier issues in this disease. There's actually immune dysregulation, not perfectly the way we think about here. It probably looks more like if psoriasis and atopic dermatitis had a baby, including some of the data that just really came out over the past few weeks at our major conference. But it seems to be a lot less about the yeast than we thought. And the same way that we think about staph with AD not necessarily being the singular factor that drives disease, but probably an associator, yeast appears to be that way as well. And so we've undertaken trying to take a look at some of the comorbidities of individuals and prevalence of seborrheic dermatitis and cradle cap, among some other studies that we're working on. And it's not totally clear about that early life relationship from what we've seen so far, but I've never heard that before. And now it does make me think that is that maybe just telling me something about the barrier more than anything else. And maybe that's the predictive capacity as well. And for that, I don't know. But this is more high-level academic debate. The practical answer would be, I don't know if we've nailed down the beautiful sign that you can see where you're like, this is going to be the one that we need to make sure that we're proactively treating. But it brings up another question. Proactive treatment doesn't necessarily seem to solve all of our problems based on some of the data that we've seen.
It has been very messy. Yeah, the prevention data is a mess. And I agree. In fact, I think the most recent Cochrane review said it doesn't work. But I take a little bit of umbrage with that because they are bringing together studies that have extremely different methodologies. And I kind of feel like
even the recent ones are very different.
They're different.
You know?
It's like, that's not scientific. You can't do different things and then say nothing worked. I think that, so I'm part of the SEAL study, and I think you are too. The SEAL study is a much bigger study. I think that will more definitively answer this question, because part of the problem is if you just moisturize the face or just put oil in the bathtub like one of them did, that doesn't answer the question. We want whole body moisturization. We want a good quality moisturizer. I think a poor quality moisturizer could potentially make things worse, right? Because creams in particular have emulsifiers, and emulsifier is kind of a fancy word for detergent. So sometimes you can actually damage the skin with a low quality, particularly lotions. That's why we're all kind of lotion averse. People love lotions. They want to pump it because it's easy and light, but that same feeling means it's high water content, often high emulsifier content, not great for your barrier. And that's why we tend to like greasy ointments. But I really think we have to answer this question. I believe in my heart of hearts that there is a signal for this, and that PACI study, or I've heard people pronounce it Paci. I don't know, maybe there's an Italian investigator. That's the I in Italian is just sound. Paci study did show not only they prevented it or at least delayed atopic derm, but they also decreased the rate of hen's egg allergy. That's a big deal, because now we're showing that second order effect. Not only did it help with the atopic, it helped with the comorbidity as part of the march. So I'm excited. But again, it's only one study and it's very noisy. And I'm not, I wouldn't bet the farm on it.
For those of you guys that aren't necessarily super plugged into what's happening, there's been a lot of studies reading out around the same time where they took this idea of, if we have really young kiddos and we just lube them up and make sure they are super well optimally moisturized with a variety of different methodologies, does this essentially delay and or perhaps negate their risk based on risk factors, their mom, et cetera? And the problem is that for every release we have, it's going back and forth in terms of saying yes, no, yes, no. And so when it's not clear what the answer is. Yeah.
I think Peter published a paper today that kind of talked about it.
Yes, that came out today. That was just a little thing, but about exactly this idea of, so what I often, and I talk about this, and I'm very interested in this idea that we get allergic through our skin. I think it's Gideon Lack did that paper, the LEAP study. I think it changed the world. In fact, even just being a little bit provocative, I was like, we all stand on a high horse and be like, you can't make major changes with only one study. We need reproducibility. Well, man, after that one study, the whole world was like, okay, pull the plug. We got to give everybody peanut butter. It was like, wow, one study, but that's how compelling it was, right? It was so robust. Everyone was just like, this is the way. That was pretty amazing. But that being said, I'll give that spiel. And then people will say, but wait a minute, you like coconut oil. And I do. I think coconut oil is really cool. Isn't that a food? Aren't you putting a food on the skin? Are you crazy? What about all the products that have oat? Whoa, aren't you going to give them oat allergy? And so we wrote a paper about it. We don't have any great answers, but it turns out we really think there is a range of the ability to tolerize versus to sensitize. And oat, coconut, wheat products, a lot of these seem to have a very low sensitization rate, even when applied to broken skin. I mean, that's exclusively who's using these products in general. So fortunately, I think we're okay. And then I usually punctuate it by saying, if you're really serious about that, then you'd have to dig out some of the other food related things that are in a lot of things. I always say, well, what shampoo do you recommend? And they're like, well, why are you asking? Well, look at any bottle of shampoo, cocamidol propyl betaine. Cocamide is derived from coconut. I mean, that's usually what we're testing when we do a patch test. So if you really are worried about sensitizing, you got to be even crazier. And I think that's why we feel somewhat. That's not to say you can't be allergic to these things. You absolutely can be. But right, how do you counsel your patients on that?
So you made a good point a few minutes ago about the actual irritants and emulsifiers and things that are in products already. And we tend to ignore those in favor of some of these as well. Honestly, those are probably doing even more harm than some of these things that we really hyper focus on that maybe not. I'm probably in the camp that you are, where I don't have enough data to specifically say that this is my protocol to withdraw coconut from everything you're using based on whatnot. And so I'm just a bit rational about it. I agree that it probably is a range. The immune system is not black and white. If there's anything that I can boil down all my years studying the immune system to, it is like a nth dimensional range of activation and activity. And so what really holds up in one person reliably, particularly in these complex mixtures that we are exposed to from the beginning of our life onwards, it's really tough to say that I can make any predictive power with it. So it's just a fancy way of saying, I wish I had smart things to say. Yeah.
Allergists, 3 in a row. You guys have anything? Yeah. Coconut oil has that GLM. Is that right? Which is. Oh. Yeah.
Sai and I love coconut oil. Do you love coconut oil? Yeah, we like coconut oil.
Just for our at-home viewers, we have consensus on
Um,
coconut oil from
yeah.
the Allergy crew, so we're very blessed.
My question is actually going further back. When you guys you were talking about this, the scoring you do in your clinics for patients' control on the severity of their eczema. I love SCORAD. I use SCORAD for all of my patients. It's more complicated, but I love SCORAD because it has pictures. So if they have low health literacy or if they have dark skin versus a Hispanic skin type or a Caucasian skin type, we can get different pictures and it can help figure out where they are. And I actually have patients SCORAD themselves if they say I'm in a flare, because I want to know. I'll write in my note their SCORAD was 49 and they were like moderate to severe eczema. And now they're saying, oh, my kid scored is a 75 or it's a 20 or wherever it's at. Do you guys like SCORAD?
So just a clarifying question, do you do both patient-oriented SCORAD as well as your own SCORAD?
We do SCORAD in clinic together. So I'll have the parents I'll have them download the app on their phone and then we'll do SCORAD together. And then I'll put the patient SCORAD in my note. And then when they come back, we'll SCORAD again together.
So you use sort of the clinician SCORAD tool and not the patient-oriented ones with the photos though, right?
Hmm.
Okay, so you're doing a patient-oriented SCORAD together.
Yeah, patient SCORAD, yeah.
Got it. Okay, so the SCORAD is largely the preferred tool in Europe and other countries. It's what their guidelines are based on. In the US, you might be the only person doing the SCORAD potentially. No, I say that sort of half jokingly, but dermatologists typically do not do the SCORAD. For those of you that are not super familiar, there's a couple of different clinical trial tool assessments that had never really migrated their way into common practice in dermatology. The SCORAD is one of them. Scoring atopic dermatitis is what it's called. And what you're essentially looking at is, an estimation of area of involvement in sort of certain areas. Then you're sort of also looking at severity estimation as well. And then there's an estimation of itch and then sleep impairment. It's all combined together into a number. And then there's an actual patient-oriented version of this tool where if they're not seeing a healthcare provider, they can have it at home in front of them and they have a reference for marking off their severity based on sort of their area of body, whatnot. And then they can submit that in. You're kind of doing the patient tool together. The other one that's commonly used that you may hear is the EASY tool, the Eczema Area Severity Index, a much more popular tool in America. And that one sort of just takes a slightly different approach to individually scoring regions by severity in a way that SCORAD does it somewhat more globally. Bottom line, they're largely really clunky for day-to-day clinical practice, particularly for dermatologic visits where usually you have minutes to make stuff happen. So you're lucky if somebody really does just a gestalt severity. We have one of my fantastic fellows has been working on a project where she dumped several thousand charts from the Northwestern system just to look at what people were documenting in the case of atopic dermatitis. It's kind of embarrassing, actually, is what it comes down to. But just to give you the sad state of affairs, only 14% of charts were even sort of putting down an objective capture of itch about whether it's like mild, moderate, severe, X out of 10, et cetera. Easy was like probably 3%. SCORAD was like 1%. And that was derms.
So let me say, you're a superhero.
Yep.
You're amazing. Like you're basically doing it 10 times better than everybody else.
We get much longer than you guys do for visits. Our visits are clocked for new patients for 2 to 3 hours.
That helps.
Whoa. That was 16 minutes.
I mean, we get 30-minute time slots, but we tell them they're going to be there for 2 hours.
Yep. No,
Because of like all the stuff.
I'd say that, derm oftentimes is compressed to 10 minutes in the real world. And of that 10 minutes, only a few minutes of it is the actual patient encounter part.
I mean, totally.
Yeah.
My aunt's a program director for Derm in Michigan.
Yeah.
She and I laugh about it.
Yeah.
Like the difference. So, okay. So I love SCORAD because I like that.
Yeah, you're amazing.
So it's not, you guys think it's fine. Because my program director in fellowship was obsessed with SCORAD. So now I do SCORAD and I make my fellows do SCORAD.
SCORAD's even better than easy because it actually has some patient-reported outcomes. It asks about sleep. So it's the best. It's just clunky. The other thing I'll say, the one you do, which is great, the PO SCORAD, the patient-oriented one, so the whole SCORAD has really been pushed by La Fondation pour la Dermatite Atopique, which is Pierre Favre in France, kind of like their Johnson & Johnson, their big nonprofit, and they have actually pushed for the PO SCORAD and they got the different skin tones. So we were all called, this is about 10 years ago, we went to Athens and spent a weekend in Athens. We all contributed hundreds of photographs. And then we met with this incredible artist who integrated all of them into design and then validated those different types of erythema and the lichenification in different skin tones. So I'm so glad to hear it. It really is a powerful tool with beautiful pictures and patient friendly.
I'm really glad that you put the pictures in because it makes the patients feel good that their skin tone is in it. So like, because they're so used to seeing Caucasian pictures of it that when they have darker skin or they have Hispanic skin tone, that makes them feel good and like they can actually do it on their own. Yeah, they feel included, which is super important.
Great. Comments you guys have are both up there. We talk about baby soft skin for a reason. We talk about, when we touch it, it's baby soft. I wonder if we're missing the visualization of the baby's skin and trying to score it and trying to have all these different metrics and things like that. I know that there's been some scoring with touch and feel and things like that, but when my patients come to my clinic, and like Aaron can probably say this too. I mean, we can see and feel the eczema, the dermatitis, or like, the xerosis starting up. And, we oftentimes, the parents say, oh, my baby's skin is fine. I'm like, well, no, it's not. It's dry. We can always see it before that. So I'm wondering if we're missing a component of like visualization and touch in our clinics, because I think the eczema starts earlier than we think. Number one. Number two, I think diaper rash is also another area too, where you got the eczematis lesion, you have, candida and things like that. There's also barrier breakdown there. And number three is why, of all the foods that we consume and touch, we're eating beef and chicken and turkey and, sesame, all these different foods, but there's only like 9 that really commonly affect the skin and can be, sensitized. So there's like complex proteins and there's, a lot of different, I guess variables there. But I believe that we need to think about how, eczema treatments earlier, even before they start to become visualized. And I think that's part of why we're missing some of our, earlier intervention. If you take a look at the LEAP trial, yes, it is the high risk, but more so if you can, in, the general population, peanut allergy is actually, if you prevent peanut allergy or if you introduce it earlier, you're going to be prevented in the normal risk population. We keep talking about the high risk population, but it's a normal risk population that we need to also treat as well.
I feel like there's a lot of very strong, smart statements in there that I'm not sure if I have anything more to add other than I think early detection would be amazing, particularly. So, here's the question. Would early detection stave off the need for systemic therapy in people that don't need systemic therapy? Or would it allow us to then say we need to start systemic therapy earlier because that would modify disease? And there's I don't know which answer would be correct. Because I feel like with this next generation of people on targeted systemic therapy, it's going to take a few decades to figure this one out, but we're going to at least have some answers to that question just because we now have medications people can be on for a long time that also target core mechanisms of disease. It's just that, again, these are usually for people with moderate to severe. And so to your point, it may not help to answer the question about somebody who's truly subclinical, but if you had to actually look at the tissue, you would see overt signs of early inflammation.
And things like transepidermal water loss, you might be able to detect.
Yeah, and I think Gideon always says the dry skin is where we should be treating. Most of our patients are. So it's there. The signal's there. We just haven't had a chance to do it. The other aspect of things too is with asthma, we've always been using Band-Aids to treat the disease, which is steroids. And here too, this is a Band-Aid. We're not getting at the root cause. So I think that if we had biologics decades ago and had those using biologics earlier on, we could probably disease modify. But right now with steroids, we know with airway remodeling, we don't change it. We only alter the disease course, but we don't alter the disease progression and so forth. So the severity and so forth like that. But I wonder if we should be, as clinicians and advocates for all the disease states, is to be advocating biologic therapies earlier than what we're seeing with right now. With Dupixent, I think is now down to 6 months, which is awesome. Because it does change the trajectory immensely. So I think that if we can start to advocate for our patients and getting these cutting edge therapies earlier, I think we can change and at least disease modify generations down the road.
We have one question from the chat. Considering the complex interplay between the immune system and skin barrier and atopic dermatitis, what emerging treatments target this cycle at multiple points, and how might they compare in efficacy to current monotherapy approaches?
That's a deep question. Yeah. So I think a lot of times we treat multiple aspects at once. We'll put a steroid on to get rid of the inflammation, help with the itch. We'll sometimes do an antibacterial if we think there's a lot of staph. And we're kind of mixing and matching these pieces. But are there other things? Of course, dupilumab, it's, bless you, IL-4 and IL-13, which do play a role in multiple aspects. So that is kind of interesting, right? It's helping both the inflammation, but also directly the itch and a little bit of the barrier, because IL-4 and IL-13 have an effect on filaggrin and ceramide production and all these other things. So when you block their overproduction, you do seem to improve all.
There is good data now from a lot of the real world or sort of phase 4 studies from dupilumab that have basically shown everything from fixing the nerves, fixing the microbiome, fixing the barrier. It's just that, they don't really tell you much about a primary effect. They're probably all secondarily related to the ability to target the immune system. And so the larger question remains, what if you had something that could really target barrier and immune system together? Would that be a magical therapy? And the best example we have is sort of one of the dirty little secrets in clinical trials is everybody's on an emollient, right? So that is the standardized approach to make sure everyone's on the same level playing field, oftentimes with the lead-in. So people are actually getting barrier-directed therapy in clinical trials, even when they're on a biologic. So those numbers are not pure monotherapy in one sense, but that is one way that you're combining something that's directly primarily working on the barrier and maybe secondarily having an immune effect with something that's primarily working on the immune system having a secondary barrier effect. Now, your question is more of what if we had bimodality where, let's say, I was either choosing a cytokine blocking plus blocking something related to the barrier, or it was a cytokine that had very, very direct effects to the immune system and the barrier as well. There's drugs like this in preclinical, like pre-phase 1 or even phase 1 and data that suggest it could be possible, but it's very early on. So I'll give you some good examples here. So there's been this long-standing story with IL-1 family of cytokines. IL-18 is one cytokine that's like that. GSK is developing a drug there, and I think they have some almost phase 1-ish data. The idea here is that this molecule, instead of IL-4 and 13 having a role sort of in more immune stuff primarily, actually plays a very early upstream role and has direct barrier effects. And there's been a lot of study in this pathway for a long time with middling data. Their data, even though it's a really tiny number of patients, suggests this might be one of the better examples we have of a barrier correction in addition to an immune part. That's just one example, but there's another trend happening in drug development to actually make bimodal therapies, essentially that bind to or attack two things. And so some area that some companies are going into is to something that will work on a barrier protein or enzyme in addition to an actual cytokine or immune signal as well. So we'll get an answer to that eventually. It's probably just a little early.
Yeah, I think right now, of the available treatments, the biologics are still really impressive for their efficacy to safety kind of index. The JAK inhibitors, we have 2 oral JAK inhibitors approved in the US right now. They're even more powerful, especially at their higher dosing, but they bring with them some more potential side effects. So right now, I think we're usually reserving those for people that haven't had luck with a biologic, but we're hitting easy 90. So 90% or better improvement on that eczema area severity index, which is pretty amazing. We're getting some of the most severe patients to almost clear, which is pretty awesome. This one, we've kind of talked about the sensitization concept versus tolerization. And I just think it's so fascinating to see how, I remember when I was in medical school, it was like, well, the allergic kids, don't give them peanuts, wait till they're more mature, wait till they're, it was so crazy. It was like, that's how you make a peanut allergy epidemic.
Yeah.
We like made it happen. And now it's just such a cool story that we flipped it around. This is that Pachi, right? This is that one showing that they were able to decrease eczema and potentially delay it, plus decrease food allergy, at least hen's egg, which is kind of crazy. 650 kids. In this one, I feel like it might have been triamcinolone or fluticasone. They use a pretty good amount of it. Thank you.
That's
Thank
pretty
you.
pretty
Thanks, Aaron.
staunch steroids right
They
there.
were not messing around. Yeah. No,
Yeah.
thank you. Thank you for looking at
No, no, I'll pretend you didn't. So that's fine.
That's intense. Yeah, that's intense.
Yeah,
That's pretty hardcore. Yeah.
interesting. Yeah.
True. Yeah, no, I think that's those are like the big ones, and this is just like the general therapeutic approach. This is my trademark, not really trademarked.
No,
3
it's
hurdles.
trademark. It's trademark.
The 3 great hurdles: getting people clear, the first hurdle, usually pretty easy. Very rarely is that the problem step. Number 2 is the big one: keeping them clear safely. That's really hard. That's the patient who's like, I put the triamcinolone or the betamethasone on, as soon as I stop, I flare up again, right? Those are the problem patients. And then the third one is, can they keep it up? And that's also tough. And that can be an issue with injections. It could be an issue with just topicals. People hate using them. I've had parents yell at me that have broken the washing machine because there's so much ointment over everything. So these are kind of the general approach that we have to use. And it's, every day you face these challenges.
Yeah, I mean, so it's a classic Peter Leo slide for a reason, right? Because the longitudinal course of atopic dermatitis is fascinating, right? Because the disease inherently in itself has its own patterns. So independent of what you do, another confounder in a lot of our trials is that we don't really standardize for people's individual course of disease, meaning that some people have seasonal disease. You hear it, right? Where they're like, I really only have symptoms in the summer or the winter, and I'm okay year round. Some people are just moderate all the time. Some people are moderate with severe flares. Some people are sort of relatively good, except for a couple bad flares during the year. And so you have to add that into the treatment problems, where we know that not every treatment is the right choice for every patient. And so in many ways, it's almost like we don't have good controls for what we're treating, just because the disease itself oftentimes has its own course. And that's the reason why, it's one reason why in my mind, it's so hard to keep it up, because you're sort of trying to play catch up. I'd say the best analogy is microbiome studies, right? We have all this great data to say, oh, this is the magic bacteria that's responsible for this, but the devil's in the details. Those are impossible studies to control, because what is the control microbiome essentially in that standpoint, other than super clean facilities where you're using one bacteria on like a mouse or something? And so until we probably factor in some of these other unaccounted for variables into our studies, we're going to have problems with these hurdles.
Slide, please.
Yeah.
But for the Zoom people.
Have you felt adult onset eczema could potentially lead to adult onset food allergies? Have you've seen anything that you've come across and said, all right, because it is going up. We're starting to see the prevalence of this, but
yeah,
just
so
curious.
The patients probably are quite convinced of it themselves. I feel like because in our line of work, I feel like people with atopic dermatitis, whether accurate or inaccurate, there's this almost innate teaching that it's something about the world around you that's driving disease, which is why oftentimes folks come in and they're very reticent about therapy, but they're like, if you just tell me that thing to eliminate, it's got to be a food, something I'm wearing, and the detergent, like I get rid of that and it's all going to be good. And part of that is our fault. Part of that is primary care education fault. Like we're not doing a good job of teaching what the disease is because like everyone's takeaway is that it's something out there driving it. And that's not always the case. And so from the adult standpoint, I will honestly say that I probably seen more adult onset disease than even sort of kiddos just based on the ratio of patients I had. And in many of those cases, treatment works really, really effectively. And I never found there to be a high new comorbid food allergy situation. It's not to say that it doesn't exist. No different than folks saying it's that thing I eat, it's those strawberries driving my atopic dermatitis, right? Like there are, as Peter will tell you, instances where, yeah, it seems like something's going on here, but like in the vast majority of cases, I don't think it's entirely super relevant.
We wish it
Kiwi
were.
fruit,
Yeah.
kiwi and strawberries.
Kiwi and strawberry. The other thing I will say though that is worth talking about, and I can't remember if we put, no, I don't think I put the slide in, but this is the last slide. It was just this recent push from Ian Miles at the National Institutes of Health. He's an allergist there, and his hypothesis was that there are things in the environment that are driving it, but not the way patients think. It's not a trigger. It's one of the big underlying kind of changes that explains this meteoric rise of allergy. And one of the things that they found was these isocyanates, this class of chemicals, isocyanates and diacyanates, and they're present in exhaust from cars. They're present in some production of plastics, things like that. And they're also present in wildfire smoke. And we know there has been a really powerful epidemiologic connection between being in the wake of wildfire smoke and developing adult onset AD. This is big. This is big. And it's one of those kind of moments where you're like, the epidemiology is sort of pointed to this. And I think there really is a mechanism here because it turns out diisocyanates are toxic, not only to the barrier, but also to the microbiome. So it's pretty fascinating to think this could be an environmental thing that's driving all of it. Plus, we think about emulsifiers in foods and products. I love the concept that part of modern life is we wash our clothes all the time, right? And we don't do it in a river with a washboard. We use these fancy modern detergents. Even if they're gentle, there's residua on there. And then you sweat a little bit, right? And that just starts eating away at your skin barrier. I mean, we're basically detergenting off our barrier, which is pretty frightening.
Yeah, I mean, I think that it's hard to think we live in a vacuum. So don't take my chuckle to say that I don't think there's sort of external forces driving disease, but it's probably a complex mixture more.
Right, and it probably isn't a direct trigger because that's what the patient wants it to be strawberries or gluten or dairy, and I want that too.
Yeah,
make the visit very short to be like, just cut gluten, I'll see you later. Have a great day. But that's not usually what it is, unfortunately. But it's more complex. But there may be something to it. The reason people have that feeling that there's something out there driving it is because it is, but it's not the way they think.
So what detergent do you use?
We just go natural.
Don't shower. Don't shower.
Any clothing. No.
No showers, no soaps, and no detergent.
Exactly.
Don't hug them after.
Aaron, what was your question before? I think we got lost in the shuffle. You wanted to ask something.
Oh yeah.
Okay.
I know we're running close to time, and I want to be kind. I mean, we can go on, but
we'll be just to like 9:30 p.m. Just a couple more hours.
Yeah, a couple more hours. I really want to know your not only antimicrobials, but just your treatment plan. Like, how do you start? And I know as a pediatrician, people are very, very scared with those little babies. So babies to older kids to adults, like, what is your normal recommendations?
Sure. Why don't you share? You talk about this beautifully. Why don't you share your thoughts and I'll sort of editorialize a little bit.
I love it. All right. Yeah. So first, I want to just talk about the antimicrobial piece because it's so interesting, and we could spend honestly all night talking about it because there's so much work here. But the first is that bleach baths, they help, but not for the reason we thought. They don't kill staph, right? They're about 1 order of magnitude too dilute. Isn't that crazy? So Rich Gallo put the final nail in the coffin. He showed it, but Lisa Beck did some work on this, Mercedes Gonzalez. It probably works through different mechanisms.
If you want to see dermatologists fight on stage, bring up bleach baths, because like that is straight up like duke it out brawl stuff. Forget about inside outside. Very strong opinions on bleach baths.
And they still
Yeah.
work, right? So I always say it's the right answer, wrong reason, right? The reason was thought to be, it was posited that, oh, it's killing staph, which seems obvious. It's bleach, but it's too dilute. But that being said, so I always, when I'm reviewing papers, I'm always like, it's been 10 years since we've known, can we please remove the bleach from the antimicrobial section? People still think of it that way. It still may help.
A good correlate is like with HS, people use hypochlorous acid, and it has
Yes.
nothing to do with infection because it's a non-infectious disease, but it's a tertiary topical for anti-inflammatory properties.
NF kappa B pathway is some barrier repair. I mean, it's cool. It's a cool product, but so that's part one. Part two is we know that in the recent JTF guidelines, I was the proud token dermatologist for the allergy guidelines. I'm so proud. They're really cool and they're beautiful figures. Derek Chu is the allergist in Canada who put it together, and they're the most beautiful figures. I wish I didn't put them in tonight, but they're really nice. If you get a chance, it's freely available. And one of the things they actually recommended against though was antimicrobials, which is really powerful. And I think most of the clinical reviews, and the meta-analyses show that antimicrobials do not work in non-infected patients. That being said, we keep talking about this microbiome. So why? I think it's exactly as you alluded to, Roger, that it's more complex than that. We're using a brick on this very nuanced surgical problem, and we have to figure out how to manipulate the microbiome more carefully. But I'm obsessed with, as you know, because all of our patients are on it, the Aaron regime. So 2-minute elevator pitch of Aaron regime. Dr. Richard Aaron, this very charming South African dermatologist from Cape Town, spent most of his practice in London and had this concept that mixing steroid with an antimicrobial in the UK and in South Africa, they use fusidic acid. We don't have that in the US, so we use mupirocin. With that plus a moisturizer base. Okay, so it's basically moisturizer, a little bit of mupirocin, and a little bit of steroid. That this is powerful. And the first time I heard it was from a patient, it's like 10 years ago, and they said, can we please try it? Can we please try it? And I look at it and I'm like, well, it's like 1 to 10 dilution. Like it's not going to do anything. The kid was like super severe. Had been on cyclosporin, all this kind of stuff. I'm like, you can have it. I'm like, you could use it on your eyelids. It's really mild. It's probably equivalent to like 2.5% hydrocortisone, maybe a tiny bit higher. Go ahead. The mom called me a week later, sobbing into the phone. I thought the kid died. I really did. She like couldn't talk. She's like, I'm like, what's the matter? Calm down. What's going on? I like freaking out. Hairs in the back of my neck are standing up. She goes, it's the best thing you ever gave us. I literally had no idea. I'm like, what are we talking about? I'm like, what did I give you with cyclosporin? No, this stupid Aaron thing. I'm like, okay. I'm like, great. I'm so glad it was helpful. Keep me posted. I'll see you at follow up in a few weeks. Then the next day, another family calls and they say, we want to try it. We heard. I give the same spiel. I'm like, I don't think it's going to do anything. Like this other family, I think they got lucky, a little placebo effect, but please, I get, okay. They called me a week later and said, it's the best thing we've ever used. I'm like, okay, something's weird. So then I, started like a tool go on day teaches, you got to start counting something. So I had tried it for a lot of kids that were having trouble, not a first line, not trying to make resistance to mupirocin out there, but kids were having trouble. Sure enough, more and more and more people like it. So I counted it up. We counted, some number of patients, and it was like 70-80% of them basically felt it was like the best thing they had used. So I still use it. I've written now thousands of times, and I do think it's not the best antibiotic stewardship. I admit I'm part of the problem for mupirocin, but that's right. But mupirocin, it ain't doxycycline, and it certainly isn't a penicillin. It's its own class. So I guess if we get resistance, we'll get it. So be it. But I really do think it helps. Now, here's the thing. Unpublished data. We did a little bit of microbiology. We plated it out. It didn't kill staph at all. So it's kind of the bleach story redux. It works for some reason that I don't understand. Skeptics say, oh, it's just because it's convenient. It's all in one. Maybe, but my patients are pretty good. The patients I've tried it on are really fastidious. Please. Dr. Aaron has different strains, and he has like 1 through 6 and is very clever. And I just keep it all the same. I just make it dead simple. So I really just titrate in terms of time. I'm a big believer in temporal titration. I'm like, you're going to do it. He has people doing it 6 times a day and then taper all this shenanigans. I'm like, 3 times a day. You're going to do it for a few days. When you're better, you're going to take a break, because I'm obsessed with TSW, something we're also not going to talk about tonight, but this topical steroid withdrawal concept where people get kind of overuse and then become erythrodermic and all sorts of issues there. So I'm crazy about steroid safety. It's true. I am pretty lucky. My practice is pretty refined now, and it's like you have to be referred in to see me. I'm very picky. I don't know if everybody, adheres perfectly, but I do have pretty crazy compulsive patients, and I think most of them do. But
I was going to say that, so if you wanted to take the devil's advocate or psych part of this, then there's an inherent desire to do well, and they believe so strongly in this very outlined regimen. Maybe they're just doing a really good job of putting their moisturizer and steroid on, and that's what's driving all of it.
I can't push back with data against that. All I can say though is these are from my patients where I've done my Leo regimes because I make regimens for people. I'm obsessed. I write a whole thing in the morning when you're flaring. I have a whole thing, and they're people that I had seen for years sometimes that I know were motivated. They didn't want to be on cyclosporin, but we went on cyclosporin, and then this one worked different. So I hear you and I can't rule it out, but I swear if you play with it, I'm pretty sure you will be like, okay, this shouldn't work. It's frustrating. And then when I talk about it from skeptics, I'm just like, don't shoot the messenger. I don't know why it works. And nobody makes any money. Like people, one time I wrote an article about it. Someone was like, what is this fiduciary stuff here? I'm like, it's generic drugs. Like it's a local pharmacy. Like,
Big New Pearson.
yeah, big new. It's like all generics. It thinks like $20. Like, what are you talking? So Sai, please. It's a great point. It also happens with fusidic acid, so it'd be crazy to imagine two different molecules that could do it, but I can't rule it out.
I mean,
Great point.
Yeah, it's a good point. I mean, the to get back to sort of the original question, antibiotics. I mean, I think that what we've all learned is that antibiotics are not a substitute for primary directed atopic dermatitis therapy. And in dermatology, all too often, I feel like it's a solution for people that aren't necessarily comfortable with, doing the next thing for someone that's really teetering into that moderate range where topicals aren't working. And you get people on long-term antibiotics because there's this weird, it's not really textbook knowledge. It's almost empirical knowledge that antibiotics are an important treatment part for atopic dermatitis. Do you feel that like sort of long-standing, almost like just inside knowledge that exists amongst folks? Because I get these people on antibiotics for a long time.
Absolutely.
But I mean, the point is that most of our data suggests that for a lot of our systemics, beautiful numbers in terms of sort of cutaneous infections in the treatment arm versus control arm, even for drugs like JAK inhibitors, where in theory, infection would be a potential side effect, and they sort of seem to lower it too. So I'd say that how do I typically handle it? If you really have a reason for using antibiotics, I'm not a big Aaron regime person. I would sort of use the antibiotic, but it's never a substitute or a long-term thing for moving upward in a therapy class or upward to a more systemic therapy period for me.
I like it. And then to the big question, the overarching, how do we get this? How do we get the disease to go damping down? And my structure for the plan is really templated out. I have a Microsoft Word document ready to go, and I'm going to plug in the details. But when you're flaring up, I like to use something strong. I like to use typically a steroid. That's where my steroid's going to go. And I like to limit that. I'm really conservative up to a week. I feel like if you're treating appropriately, 3 to 5 days, it should be better. And if somebody says, oh, you need to do 2 or 3 weeks, it's like, I think you're under treating. Like it should be fast, right? And then when you're better, you could go a day or two past. I'm cool with that. But when you're better, then I like to take a break from the steroid. And if you don't need anything, if you're more mild, great. I want you drug free. I'm not trying to push anybody's drugs. I prefer my patients to be on no medicine. So steroid when you're bad, moisturizer when you're not. A lot of people, that's that second hurdle, right? How do you keep somebody clear safely? Really tough to do. Can't go back. That's fine. But you know the slide. And for that patient, then I would go from steroid to a non-steroid. And now we have a few different things. We have our topical calcineurin inhibitors, tacrolimus and pimecrolimus since 2000 and 2001. Then we had a long drought. Then we got crisaborole, our phosphodiesterase 4 inhibitor. And now, just in the past couple of years, we got our first topical JAK inhibitor, right, with ruxolitinib. All those, I think, are suitable for that role. Once you're a little bit better, you can use those. And then at the first sign of something, or even a maintenance or proactive therapy twice a week, which is the work of Andreas Woldenberg in Munich, and Amy Paller and others have kind of substantiated that you can actually prevent flare-ups, just like the allergists have been doing for decades with asthma. You're not always chasing your tail, right? You set the world on fire with this concept. How about proactively treat and prevent flare-ups? Quit chasing.
Yeah, the most recent data we have is from crisaborole, a drug that's often maligned just because many people view it as very fancy ointment that doesn't do much. But there was a very long study that finally read out that showed that if you sort of treat people good, long, and hard twice a day, 12 weeks or so, and then you sort of transition them into once daily treatment, and they called this proactive, the folks flared considerably less than ones that were not on that regime. And I'm not sure if you can call regular daily application to truly be proactive in a sense, because that's still a lot of burden on patients, but it does raise the idea that with many of our treatments that are not necessarily systemically dosed, that potentially whatever you define as control, modification, remission, we don't need to get into that debate, you could potentially be doing that with some of our therapies.
When you guys are, so I also do a flare and maintenance regimen. I feel so validated. I love it. So, and it's also like written out for the patients. They have them put it on their bathroom mirror. When you're doing your, I don't have them usually do a twice a week maintenance, like topical steroid or calcineurin inhibitor, whatever you're doing. When you do that, do you have them only put it on their hot spots where they normally flare, or do you have them do it systemically?
If they have hot spots, then I like say just put it to the trouble spots, or if you see anything, the first sign of anything, kind of be ultra on top of it. If they're some of the kids that are kind of bad all over, I might say go ahead and just do a whole coat. You can just kind of put it on a couple times a week to all the areas, and then that's not forever, right? That's until I see you in a few months, because what I find is this, and this is controversial, but I really believe this. I think we can modify disease, at least in the shorter term, to get people who are out of control under really good control, and then I find I can start subtracting things.
Yeah.
And I wrote a whole paper about pulling people off of dupilumab, and they stayed a relatively remittive state, which is pretty awesome.
What's your favorite emollient? A lot of my patients don't like Vaseline because they also don't want to wet before they use the Vaseline, and then it breaks their washing machine, like you were saying. So I usually have them do Vanicream or CeraVe are my two favorites. Do you guys have other ones that you like better that are not the super expensive $3,000 one that it's just
Yeah.
hopefully-
So, let's just talk totally common over the counter stuff, because it's a lost area of science and specialty and derm. We were the ones that understood formulation and what goes into topicals, but we never get taught this stuff. And unless you seek it out, you don't really know. So, believe it or not, I'd say that the science, and admittedly, I'll just say the major conflict here is that sort of I've done some of the investigatory work. The science behind the Beiersdorf products is pretty reasonable. So that includes Eucerin and Aquaphor. Like there's actual reasonably well designed studies. And so Eucerin from an actual cream standpoint is one I like, as well as Vanicream. Those are two that I probably use in my clinic.
Do you guys see it? So I have a lot of parents that don't like Eucerin because they get like they don't like the lanolin. Do you ever see that, or is it just like my own personal thing?
Yeah,
that you
so
see?
for the actual purification scheme, if you actually look at sort of the way the wool wax and lanolin, and there's actual some reasonable good data on this that's been published, it's actually highly infrequent on Eucerin based on their proprietary sort of extraction algorithm. And if you actually take a look, and they did sort of a comparison side by side with other products, the pure product in Eucerin, it's very infrequent. And so that was one that sort of was always on my mind, and it's an important one to work through. It has not been a problem with that particular product, which is why I'm comfortable usually talking about the usuals and keeping that in my discussion. But in terms of the most inert, probably Vanicream is probably among the most inert, just because it previously used to be a compounding medication cream that ended up getting sold directly to consumers as an actual moisturizer. But CeraVe's data is pretty reasonable. Like I said, Eucerin's data is pretty reasonable. Yeah, both Peter and I have kind of worked with a little bit in the OTC space as well, and I think that from my digging, I've felt like the science is pretty reasonable behind some of the stuff that L'Oreal does and La Roche-Posay, as well as Beiersdorf too. So.
Yeah. And then if you want something, sometimes patients have tried stuff and don't like it, then sometimes I will recommend the French brands because they're a little bit different. They're not super expensive, but Aven is a brand that I do like, and I work with them in many capacities. And La Roche-Posay, they make really nice products. I work with them in capacities. SkinFix is a Canadian company that I like. I work with them in some capacity. CeraVe is wonderful now, actually bought by La Roche-Posay. So they're actually part of that French company, and that's why they've gotten rid of some of the ingredients. The ceramides in CeraVe were originally bovine. They were from bovine brain. And when the French company took over, they were like, no. So then now they are, it's a phytoceramide based, which is
So
kind
interesting,
of
because I'm pretty sure there's that classic French dish of scrambled eggs with calf's brain. If I'm
Oh my goodness.
We do have a question in the chat. Someone mentioned they struggle with eczema, frequent flare-ups. They're wondering what any lifestyle modifications or daily skincare routines could help manage these symptoms more effectively.
Yeah, it's kind of like we talked about before, right? So definitely don't want to see here and give a one size fits all approach to somebody's very specific question without knowing everything about them. But There's the basics of eczema treatment. So I would say that, when we think about atopic dermatitis therapy, it's stepwise and additive and sort of is somewhat pyramidal shaped. So usually underlying most things for people with relatively clear disease or very mild disease, the two things we try to optimize in every visit, or at least early on, are bathing and moisturization and trigger avoidance. Those are like the three things that dermatologists focus on that see a lot of atopic dermatitis. For a lot of people that are very, very mild, that might be sufficient to actually keep them under control, and you don't need to go a topical pharmacologic route. If that really isn't doing it, if you really aren't doing a good job of figuring out potentially what triggers might be, being pretty good about at least proactively trying to moisturize, so thinking about what you're doing in terms of bathing, then that's when topical anti-inflammatories come in. And so for this particular patient, if they're not using something pharmacologic, that might be the next step to think about. And that's when we talk about topical steroids, calcineurin inhibitors, JAK inhibitors, phosphodiesterase 4 inhibitors, some newer ones that are coming as well, a very, very large category. And then probably the next bucket up from that would be your systemic therapies. And so that's kind of how we think. And much like my friend here says, I'm all about stripping away things that I don't have to use. And so as we move up in terms of steps, you can probably take away some of the lower steps and it matters a little less. And so while I don't recommend this for everybody, if you're on a systemic therapy, you can sometimes be a little lazier about your moisturization and bathing and not as rigorous, and you'll be okay because of what you're on. It makes life a little easier.
Could we actually step that back? I'm thinking of like the everyday person and bringing that into lay language a little bit. Like, let's say you're on a 3-month wait list to get into your dermatologist. Like I know many of us are.
6 or 8.
6 or 8 months. Okay, good point. 6 or 8 months. And you're dealing with a, semi-frequent flare-up. Like what can I do morning, noon, and night? And let's say I work out once a day or maybe 3 times a week and I'm trying to control it. And I'm your everyday user. I am a middle income woman and I need some support. Like, what does my routine look like? What are the products I can focus on? What can I do until I can finally see somebody?
Does she suspiciously look like you? No, I'm joking.
I mean, they probably does.
No, I think it's important. So I think the things that we can say pretty universally, and I was just going to also say, I love this kind of the therapeutic ladder. And sometimes patients get mad. They're like, why aren't we focusing more on the root cause? Like Sai brought up, it's like, why don't you do food testing? And it's in part because it's usually not where the money is. And B, it can be difficult to interpret when everything's going crazy, right? Like I can't even do patch testing if your back is bright red. It's like, I got to get you down a little bit so we can kind of sort this out. We got to put out some of the fire. So that's why I will escalate a bit. But yes, everybody I think can use a gentle cleanser, and there are lots of good ones. I'm obsessed with the oil-based cleansers. Eucerin has a really nice one. CeraVe has kind of a version of it. Aven has a nice version. They're oil-based. They're not terribly pricey. I think they're awesome. A really good moisturizer, and again, we mentioned a bunch from Cetaphil to the heavy things like Aquaphor or CeraVe Healing Ointment. Any of those are awesome. One that they like. A great resource for those is the National Eczema Association has a seal of acceptance program that has a whole bunch. I mean, now it's like hundreds of products that sort of meet these stringent criteria. It doesn't mean it's going to be good for everybody, but it's a great place to start. So that's an awesome resource. And
with the use of these, typically what you're going to want to aim for is at least once a day. Best time is usually after you get out of the bath or shower, and you shouldn't be avoiding bathing. That's a common practice. We used to say, all right, it's going to dry out your skin more, like bathe irregularly. We actually encourage regular, whatever your idea of regular is, showers, baths, and whatnot. But the key is to really time your moisturization practices with that. Sorry to cut you off.
No, please.
That was my additional 2 cents. And if you are unable to get a prescription therapy, number one, you could use the same emollients that we talked about in the way that we would use a prescription twice a day if you'd like to, but sometimes hard for people to do. And then there's over-the-counter options potentially for hydrocortisone-like medications, if that's something you want to try. For people having pretty bad flare-ups, I'd say that the assistance is sometimes nominal for 1% hydrocortisone, but if you're unable to get into a dermatologist, it's not unreasonable. Vanicream actually has a very nice, gentle 1% hydrocortisone formula. I believe the other major ones too, CeraVe may have something like that in that regards, but there's a lot of people that make various formulated 1% hydrocortisones.
Well, I want to be cognizant. It's 7:30. We said we would end at 7:15. So if people have places to go, feel free. But this is super helpful. I think we have a couple more questions, but I don't know. Should we take it offline and people can chat? Any pressing last minute words?
Just that I think that more than ever before in history, we have the tools and the know-how to get people better. So I really am excited to meet patients who kind of had a bad experience 10 years ago and are like, these guys all give me the same triamcinolone 1 pound jar. I want them to come back, right? We want people to come back because we have some new ideas, new treatment options, and I think we can get people better than ever before.
Yeah, I'd say that my 2 cents is, historically dermatology was always thought as the specialty of two things, right? One, if it's wet, make it dry. If it's dry, make it wet. Or we're going to essentially give you a topical steroid that has a fancy name on it that is essentially a hydrocortisone-like medication, and that's all we got. And, in all honesty, that is all we had for a long time. But we kind of were on the most exciting era, particularly for atopic dermatitis. Like, it's finally getting our due. And the years that we put in, where we actually have a lot of great therapies that are not specifically topical corticosteroids, that are targeted to things that we've learned about the disease itself that actually work. And so it actually is a discussion involving more than just one or two things that you feel like every derm has talked to you about. So if anyone out there feels like they're having that same discussion, just note that maybe it's just a matter of finding the right therapeutic alliance to talk about a lot of those changes, because it really is, in fact, it's like so many options. I feel like we don't even have time to talk about them during visits, because by the time you actually get to hearing about the entire journey of eczema, you're like, okay, now we need another 30 minutes to talk about all the treatments that are available to us. So it's a great time to have eczema if you really had to have eczema, and we're getting even better understanding with the therapies we have every day.
That's awesome. I have to say, so exactly what you said. We say that all the time in food allergy. It's such a great time to be in food allergy because of so many new treatments, and there's actually hope. And same with derm. There's so much new stuff coming around. I have to tell a story. One of my best friend, my best friend from high school, I hadn't seen her in 10 years and went back, and we were having dinner, and she's telling me her journey with eczema and how horrible it was and how she was steroid resistant. And she's like, I'm so sorry. I came to Chicago. I didn't tell you, but I had to see this one doctor. And I'm like, it wasn't Peter Leo, was it? Yes. And he put her on dupilumab, and it completely changed her life. So the whole idea of this new treatment, and now she is like the happiest ever. And nobody believed her with her steroid resistance. And I think she found it on Facebook. So social media, yay, one win for them. And so I do agree, like it is a great time, but it's important that all your knowledge, to Elizabeth's point of it's not easy to get to specialists. So how do we get that knowledge into primary care and to people who, because I can still tell you pediatricians are so resistant to using a lot of these treatments, and how will these treatments impact the whole atopic march, like dupilumab? If you start them at 6 months, do we have a chance to reverse and develop tolerance to food allergies? And that's something we're really interested in. So all of us working together in our fields to like make real change happen. And I love your discussion of no soap, no cleansers or emulsifiers. Or I know I was at another talk and they were talking about the TCS and toothpaste, and you shouldn't be using is that what it's called? TCS? Huh? SDS. Thank you. Whatever. 3 letters that are really bad for you. But like, how do we get away from all the things we're doing to ourselves in modern society that may not be good for us? And how do we learn which ones don't have those things? And I think society is moving that way. So it's really positive. So no more bathing, no more soaps, no more detergents.
Be like us. That's right.
Or toothpaste. Yes. No more toothpaste. We're all going to come to work. Well, yeah, love what we learned tonight. But thank you both so much. And if you don't mind, like a couple more questions, maybe we'll come up and ask you. Oh, I have to say, CFAAR produces some amazing people, like everyone in this room. Well, not everyone is CFAAR, but everyone is CFAAR. So I have to say, Olivia is one of our former research assistants, interns before that. And she just matched in derm. Yes. She will be your colleague very soon. So thank you for being great mentors to her. Okay, done.